Good morning, students. Myself, Dr. Apeksha Dhole, Professor, Oral Medicine and Radiology, working currently at VSPM Dental College and Research Center, Nagpur. Today, I'll be teaching you myofascial pain dysfunction syndrome, also called as Mpds. Now, this is an extracapsular cause for temporomandibular joint disorder. Now, before begin with this topic, I just want to learn you something which you have known, which you know in your first year. That is, there are muscles, that there are three muscles: cardiac muscle, smooth muscles, and skeletal muscle. Cardiac muscle, which is present in the myocardium; smooth muscles, which are present in the viscera, that is, example, intestine; and the skeletal muscle, which are responsible for the movement of the joint, and they are attached to the skeletal structures. Now, one more thing I have to ask: have you ever felt that some of your muscle become more painful? For example, calf muscle, biceps, or triceps, after you do a strenuous exercise or after a trauma to those particular muscle? I think yes. And we all have failed performed the management for particular muscles also. Some part similarly on that ground. Today I'm discussing myofascial pain dysfunction syndrome. Here, the muscles, that is, the skeletal muscles involved are the masticatory muscle. So, here we go. The topic will be discussed under these headings like definition, terminology, etiology, pathogenesis, classification, clinical features, physical examination and diagnosis, management, and conclusion. Now, students, here again, uh, for your examination point of view, each and every point is important for your short questions. It can be asked, Mpds can be asked for a long question where you are going to elaborate all those things. It can be asked for the short question. It can be asked only definition, only etiology, only pathogenesis, only management part of it, or either of the entity. Any entity in the management part can be asked as a short question. So let's begin with the definition. Myofascial pain dysfunction syndrome is a pain disorder in which unilateral pain is referred from the trigger points in myofascial structures to the muscles of head and neck. Now the pain gets referred to. It means from the area of origin it gets to the different area, to the distant area. Pain is constant, dull in nature, in contrast to the sudden, sharp, shooting, intermittent pain of a neuralgia. This pain of Mpds is dull, constant in nature. Now, what are these trigger points? The myofascial trigger points is clinically defined as hyperirritable spots in skeletal muscle that is associated with hypersensitive palpable nodule in a taut band. We'll come to know how these trigger points or these taut nodules or taut bands they formed. The spot is painful on compression and give rise to characteristic referred pain, tenderness, and motor dysfunction. There are different terminology before we start with this myofascial pain dysfunction syndrome. Like Costin in 1934 called it as a symptom complex, as there was pain in ear, sinus, and in the facial region. Schwartz in 1956 called it as a temporomandibular joint pain dysfunction syndrome. But since 1969, when Laskin has termed myofascial pain dysfunction syndrome, we are using the same terminology. Now, what is the etiology for Mpds? It is the muscle which gets fatigued or it is in the spasm. Now, this muscle, why it gets because there is a hyperfunction of muscle. Now, why this muscle is in a hyperfunction? It might be because of these mentioned etiologic factors like disturbed occlusion, bruxism, secondary to stress and anxiety with occlusion, then internal joint problems such as disc displacement, degenerative joint diseases, parafunctional habits, prosthetic problems, psychogenic cause, or the sleep disorders. The basic is either it may be dental origin, it may be the anxiety, stress, it may be because of certain parafunctional habits, or it may be because of the internal disderangements or the joint. Now this is a um, diagram which shows The middle part is myofascial pain dysfunction. Now, it starts with the stress, which will cause muscular hyperactivity. Now, this muscular hyperactivity is maybe because of dental irritation, dental malocclusion, which may gives rise to the muscle fatigue and then myofascial pain dysfunction syndrome. Now, because of this, there might be this occlusal disharmony, there may be internal derangement, there may be contracture, there might be degenerative arthritis, which will lead to the altered chewing pattern. Now, this altered chewing pattern in turn will cause the myofascial pain dysfunction syndrome. And this cycle goes on. Because of myofascial pain, there is occlusal disharmony, or because of occlusal disharmony, there is myofascial pain. Now, this is a vicious cycle which goes on unless and until you break the cycle. Now, in 1969, Laskin proposed pathogenesis behind myofascial pain in orofacial region. Now, we all know the nerve is surrounded by or is stimulated by the muscle is stimulated by nerve, that is neuromuscular junction, what we say. Now, the stimulatory factor, the muscle, it gets stimulated because of certain factors. Like in this case also, when this masticatory muscle, it gets stimulated by stress, occlusal disharmony, trauma, or the other mentioned etiologic factors, the muscle will cause hyperactive. And this hyperactivity of a muscle will lead to the depletion of calcium and ATP. Prolonged and sustained muscular contraction. This will lead to the prolonged and muscular contraction, which will lead to the firm taut. Now, normally there are no taut bands, but once there is muscle which gets contracted, there will be formation of firm taut bands within the muscles. Okay, the contracted muscle are thought to reduce the local circulation by compressing the capillary. Now, the muscles which is contracted, now the contracted muscle, it will cause the compression of a capillary which are present in that particular area. Now, this capillaries, once it gets compressed, the circulation will be less. There will be less circulation, there will be vasoconstriction. This will result into the lack of local oxygen supply into that particular area where these changes has been taken place. Now, this local hypoxia or reduced oxygen level is associated with the release of endogenous inflammatory substance. Now, what are these substances? These are all substances which will lead to the inflammatory component and pain, like prostaglandins, bradykinin, serotonin, histamine, and interleukin. Now, there will be activation of group 3 and group 4 nociceptive fibers, and there were pain. Pain, what we say on compression of these knots or the trigger point, it will be elicit. The pain will elicit. Now, the above structure, the middle one is the trigger point. This is a taut band of a muscle. Normally there are no taut bands, but the muscle which is hyperactive, the muscle which is compressed, and there are formation of trigger taut band and the trigger zone and the trigger point. Now, in which patients the Mpds are more prevalent? About 50% of population has the chronic head and neck problem, but 6% patients they need treatment. Around 20 to 40 years of age group is commonly suffered, and females are more prone in the ratio of 3:1 or 5:1. Now, what is the characteristic feature or characteristic pain in Mpds? Pain is usually continuous, dull, diffuse, and deep quality. Pain will increase during muscle activity. Like masticatory muscle, what is the action? It will be chewing, grinding, speaking, all those opening, closing movements. All those movements will cause the pain. Pain persists even on night. Then pain radiates to the surrounding area like head, neck, ear, or in the temporal region. There are associated symptoms like sudden withdrawal pain when palpating the trigger points, clinical signs like bruxism. Like when there is bruxism, you have to think for a wear facets on a teeth, teeth mobility, hypertrophy of a masseter muscle. When there is bruxism, the patient will have a constant muscle activity during night time, as well as the muscle will be active in the anxious phase. So there will be hypertrophy of a masseter muscle. Functional limitation or deviation of mandible upon opening, pain radiate to the surrounding area such as ear, TMJ, toothache, maxillary sinus. Other features like headache, tingling, teeth sensitivity, ear pain, tinnitus, dizziness, vertigo-associated fatigue, nausea, vomiting, excessive sweating, and skin flushing. Now, all those examples I have quoted, that associated symptoms, I have to think for which muscle is involved and which muscle, after involvement of that muscle, what will be the area of that pain, where the pain it radiates. Now, for example, if the masseter is involved, pain will radiate to the maxillary and mandibular teeth, TMJ, entire facial muscles, sinusitis, deep ear, frontal and temporal headache. Now, temporalis, if it is involved, it is maxillary tooth pain, temporal headache. Medial pterygoid, mouth, tongue, pharynx, hard palate, and behind the TMJ will may lead to the nauseating uh, symptoms. Then lateral pterygoid like zygomatic area and maxillary sinus TMJ. Now we have to think that what is the origin and what is the insertion for that particular muscle. What is the movement of muscle? It might be only one muscle, one or two muscle, or there might be all muscles which get involved. But usually it is an unilateral muscle involvement. Either of these muscle may get involved, so you should understand what is the muscle involved and where the pain is radiating. This is for diagnosing the muscle. Now we know that there are certain pain criteria, yes, there is certain associated symptom, but to label, yes, it is an Mpds. Laskin gave some diagnostic criteria. Now what are those criteria? First is unilateral muscle pain. There will be muscle involved, muscle will be tender, clicking in the joint, then limitation of the jaw movement. Now there are two negative points that should be there: an absence of a radiographic evidence of an organic changes in joint itself, and lack of tenderness in TMJ. What does that mean? That there is no abnormality in the temporomandibular joint. There is no bony pathology exists, and this is particularly exist in the muscles of mastication. Understood? Now, how I'll diagnose the patient? If patient come to my OPD, what should I do? The history should be taken very thorough. Now, here the complaint will be first either the movement is reduced movement, or the first and foremost will be pain while movement. So I should ask for site, mode of onset, duration, frequency, quality of pain, time of onset of the pain, time of the day at which the pain occurs, the time when it becomes more pronounced. This pain history is very important. Apart from that, I should ask for occupation of patient, sleeping habits, parafunctional habits, history of previous trauma, prolonged dental treatment, emotional stress and associated symptoms. Why? Because to rule out what is the basic, or to rule out rather to know what is the etiology for this particular patient. Then once you know that the once you know the history part, you should go for a physical examination: articular joint, muscular, dental and cervical. Now in articular, temporomandibular joint should be evaluated for clicking, tenderness. Then muscles of muscular examination for trigger points. The muscles are masseter, temporalis, lateral pterygoid, medial pterygoid muscles should be checked for. The resistance test is performed. The muscle of the muscle's action is made, and the resistance is examined. The muscle which is involved, and if you felt the resistance to that, if you feel the pain on that particular movement of the muscle, you can think that these muscles are involved. Then dental occlusal evaluation, it is very important, because there might be gross occlusal discrepancy, premature interferences, anterior open bite, reduced open bite, vertical dimension, reduced vertical dimension, atresion, wear facet. You should not lose any of these points, because the smallest error in your examination, you may miss the diagnosis and you may miss the management part. So it's very important that type of malocclusion, skeletal, whether it is dentofacial, only dental, dentofacial, skeletal, it should be checked for. Then cervical examination, as the cervical neck muscles, they are accessory muscles of mastication, they should be palpated. Then few radiographic examinations should be performed with the help of radiographs, conventional as well as sometimes you may need some specialized radiography so as to rule out whether TMJ is involved or not. Now, once I think that this is an Mpds, what should I do? I should rule out the other appearing symptoms, other lesions. Now, what is that? First and foremost is pain which arises from the odontogenic cause. What are the most common odontogenic cause? It might be pulpitis, periodontitis, pericornitis. How I'll rule out those things? Now, if it is because of pulpitis, there will be decayed tooth. It might be with or without tenderness. If it is periodontitis, there will be deep pocket, recession, mobility, post discharge from the sulcus. If it is because of pericoronitis, there will be inflamed pericornal flap along with the partially erupted tooth. If these are the things present, you should think for this might be the first cause for pain. So when MPDS is there, you should think for first odontogenic cause when the to rule out. The second is myositis. Myositis, there is a muscle which is inflamed and so there is pain. Sign of a muscle inflammation will be there, and pain, redness, swelling over the swelling. Usually acute trauma may lead to the myositis. Then pain specific to temporomandibular joint. This is usually because of internal disc derangement with reduction. Now here there will be click sound. Then mild pain will be there. Internal disc derangement without reduction, there will be lockjaw. It might be because of septic arthritis where there is redness over the affected temporomandibular joint. It might be because of discitis, synovitis where there will be severe pain on the TMJ area during mouth opening. So these are the areas where TMJ itself will be painful. Then the next will be trigeminal neuralgia. As we all know, the trigeminal neuralgia, the trigeminal nerve branch will be affected. That is, nerve dermatome will be involved, and it will be limited to that particular nerve branch. Okay, and the presence of trigger zone like aloft nose, cheek, etc. will be involved. In case of an MPD, there will be triggered points which are present in the muscle. Okay. The next, this pain of a trigeminal neuralgia will be for a short span. It will be electric shock like, and it will come and it will go off. While in case of an MPDS, it will be dull aching continuous type of pain. Okay. The next entity will be atypical facial pain. Now, atypical facial pain is continuous and persists even on night time, but the trigger points are absent in case of an atypical facial pain. Otitis media, the name itself, it is the ear pain. Now, ear pain, it is an associated pain, it is an referred pain in the MPDS. But when it is because of an otitis media, the pain will limited more towards ear with or without post discharge from the duct orifice, and the muscle of mastication, masticatory muscles, they will be non-tender. If it is because of parotitis, there will be swelling in the parotid gland, post discharge from the gland, or you should think for the reason. Now, whenever there is pain we are suspecting, there will be inflammatory cause. It may be bacterial, it may be viral etiologic factor. But more commonly, the pain elicits in the bacterial cause. That is, post discharge will be there from the duct orifice. And again, when you palpate the muscle, they will be non-tender. Sinusitis, the sinus area will be tender, and history of cold, pain, the pain will increase on lying down on, and the muscles of mastication will be again non-tender when you palpate in case of an sinusitis. So all these were the list of a differential diagnosis. What do you mean by differential diagnosis again, students? That means you should think for all these regions before you call as an MPDS. Clinical diagnosis, clinical features, physical examination gives you that yes, it is an MPDS. But my second thought should be for all these other differential diseases or differential lesions, I should rule out one by one and then come to my final diagnosis. Now, why I'm again calling it as a final diagnosis? Because the definitive diagnostic in criteria are whatever I have enlisted, the clinical examination and ruling out all the differential diagnosis. Now, once you diagnose, the management part is very important. Now, management is can be classified or can be divided into these different areas like education of a patient for self-care, then pharmacotherapy, alternative heat and cold therapy, physiotherapy, like TENS, biofeedback mechanism, intraoral appliances, stabilization. This is multiple etiology and multiple therapeutic the management techniques can be applied. Now, in some patients, you may have to give only one, two, or most of the one combination of the technique should be used. Now, Levine proposed the five method of a behavioral modification. Now, this is in case of MPDS, usually it is the anxiety considered to be the most stress or anxiety considered to be the main etiology, and so behavioral modification is considered to be the first considered first in the management. Now, what do you do in this? Re-educate. Educate the patient. Now, patient is know about the whatever the pathology he is suffering from, why there is pain. But he might be wrong. You have to educate the patient what is the cause, what is occurring, what has occurred to the muscles, and why there is pain. Why there is pain into that particular muscle, and why there is pain into the area which is distant to that particular area. Okay, this re-education of a patient is important. Reassurance. Second is reassurance. That is, you have to give a patient in a very calm attitude that this entity is benign and it is the muscle which gets spasm, and once you we treat the things, there will be no residual deformity and the things will be normal. Okay, whenever you are giving suggestion, it should be, we have to make the attitude, your attitude should be calm and patient has to be make comfortable. Now, self care, we have to take patient in cooperation. Here patient cooperation is needed, and so the behavioral modification, we are changing patient's behavior. Why? Because we need his participation, his or her participation for the benefit. Now we have to ask the patients that they are going to eliminate the oral habits. Now we are not there for 24 by 7 with them. So they are going to observe their habits and then they are going to manage their habits. Okay. Then interpretation, clinician should focus on what the possible cause. Now this, there might be some etiology factor which is very obvious, but there might be some factors like earlier also I told that the stress may be because of some psychological problem. The psychological problem may be in the family, maybe in the house, wherever the person is performing his duties. Now there might be the any reason. You may inquire about those things and you have to counsel the patient accordingly. Now there are certain instructions given to these patients, like notice any clinching, grinding or tapping of teeth or any rigid holding of a jaw. We are going to ask the patients to notice these changes. Then ask patient to check for tooth clenching while doing any daily physical activity, and also when experiencing overwork, fatigue and stress. They are going to observe what they are not observing up till now. Okay. Then avoid biting unilaterally, avoid consumption of hard foods, food that require wide mouth opening. Now once they observe, they know that what is the wrong thing they were performing. Now we are giving some instructions that what should be avoided and how they can improve. First is avoid biting unilaterally, but what should they do? They should do the bilateral consumption plus avoid of hard foods, but they should use the food which is soft can take the soft, can make it the in pieces, or the liquid diet, if possible, for a few days. Then avoid habitually clicking of jaws. If a click is present, avoid habitually maneuvering the jaw into positions to assess its comfort or range. Now this is very peculiar in patients. क्या करते हैं पेशेंट यूजुअली? कितना मुझे दर्द होता है, आ करके देखो क्लिक कौन सी पोजीशन पे होता है, आ करके देखो क्लिक क्लिक, हाँ यहाँ पर होता है, यहाँ पर मुझे पेन होता है. एंड दे डू गो ऑन डूइंग इट मेनी टाइम्स इन अ डे, and they don't know that this habit may again aggravate their pain. So we have to make them sure that they are not going to perform these clicking or other maneuvers. Then avoid sleeping in postures that place the jaw in stress. Avoid elective dental treatment while symptoms of pain and limited opening are present. Now this is again very important during yawning. Support the jaw by providing mild pressure underneath the chin with the thumb and index finger or with the back of the hand. Now we know that there is muscle pain, there is muscle inner spasm, there is underlying cause of the anxiety and stress. So pharmacotherapy plays very important role. NSAIDs plays important role in reducing inflammation and pain. Now we have a list of medicines. The example I have quoted very few, that is diclofenac, aceclofenac. Then centrally acting muscle relaxant, it will reduce the muscle hyperactivity. Metaxazone, tizanidine, clozaprazole, all those things. Now, whenever you are giving this muscle relaxant, centrally acting, you have to think that there's one of the effect is drowsiness, and so should be avoided in the daytime and when patient goes for the work at their workplace. Tricyclic antidepressants or anti-anxiety drugs or sedatives, they should be given to relieve the anxiety, to relieve their stress factor, and to improve the quality of sleep. Now again, these medications should be under medical supervision. Now, this is very common. I think we all have applied hot and cold therapy. Moist heat opens the capillaries to promote an increased blood flow, and ice is quite effective for reducing muscle swelling and pain, especially in acute situation. Now, you can go with the combination. You can ask patient to do the combination of alternative use of heat and cold. Will maybe effective. How the heat will cause vasodilatation and cold will cause vasoconstriction leading to pumping mechanism, and the tissue will heal faster. Now refrigerated spray. Now most of us may have used that Volini spray the similar way, but now this area is a maxillofacial region, eye, nose, ear, all those things. So we should be very careful whenever we are giving these sprays to the patient. Then vapocoolant spray such as ethyl chloride, fluoromethane is used to reduce the muscle spasm. Now this will act by counter irritation. Again, whenever we give, the skin should be protected. Now, this is the very old and effective method of a pain relief in the temporomandibular in Mpds. Now this is a transcutaneous electrical nerve stimulation. This is performed in the physiotherapy department. We have a very established physiotherapy department where this technique is being given in such patients. Now this is simple non-invasive analgesic technique. During TENS, pulsed current are generated by a portable pulse generator and delivered across the intact surface of skin via pads on the electrodes. Now what is there? There are certain advantage, disadvantage, contraindications for this technique, but these are this the patient is particular muscle is when identified, electrodes are placed, and the electric current is given. Now, so there are certain steps. You are going to gradually increase the intensity until the patient experiences first tingling sensation from the stimulator, then gradually goes on increasing so that patient will feel the strong but comfortable tingling sensation. The intensity should not be painful or cause muscle contraction. Apply it for 10 to 15 minutes and then gradually intensity should be reduced. The cycle should be repeated 10 to approximately um, 10 to 15 minutes. Stabilization appliances, occlusal splints. Now these are used to distribute parafunctional forces equally to everywhere so that the forces placed on the masticatory muscle could be reduced. Now these are given when there are um, dental or occlusal discrepancies, or when the patient is having parafunctional habits which are causing forces to the masticatory muscle. Now, like for example, bruxism, we have seen that the muscle is hyperactive, it is hypertrophy of a masticatory muscle occurs. So, what these appliances will do, they will distribute the forces on the tooth and relieve the muscle. These appliances also protect the occlusal forces of teeth from chronic nocturnal bruxism. Usually, patient is instructed to wear the splint only at night as long as the parafunctional activity is controlled during day. The splint should cover all the maxillary and mandibular teeth and have bilateral posterior contacts with little or no anterior contact. Stabilization appliances should feel comfortable to the patient when fitted for the first time and re-evaluated after 1 week. Adjustment should be continued every 3 to 6 months due to changes that may result in the form and function of a splint due to chronic bruxism. That means once the appliance is given, you should not ask patient to leave your OPD. No, it has to be monitored, and once your bruxism is taken care, you can discontinue the appliance. When there are certain changes, uh, then there might be certain treatment required because of in the prosthetic, or there might be some treatment required in case of an orthodontic cases like orthodontic treatment. Anesthesia. Now this next entity, anesthesia, here the injections of local anesthetic agents are given to the trigger zone. Now local anesthetic agent which is used, it should be without vasoconstrictor, that is without adrenaline. What should be done? Now it is first isolate the trigger zone, probe gently that hypersensitive tissue, and then once you identify that area, slowly go on depositing the anesthetic solution and perform the movement. And once you have that muscle pain pain removes, you perform slight movement of that particular muscle. The next entity is biofeedback. Now it is rapid method of achieving muscle relaxation. Biofeedback is the use of special equipment. Like in this case, there is an EMG, that is electromyographic machine, biofeedback machine, is to isolate and identify certain physiologic parameters and display them to the patient so that these parameters can be modified. Now, what does it mean? Now, for example, if a patient is having masseter muscle involvement, this EMG machine will show the certain changes in the form of contraction. Now, you have to ask patient that tell patient that these are the changes in your masseter muscle. Train patients few exercises, and patient will be then perform the movement, the exercises, and the masseter muscle will be will be taken back, uh, will be will come back to the normal position by the efforts of a patient with the help of this EMG machine. This is biofeedback. Then massage, I think we all know massage. It provides the relief from muscle spasm and also improves the local circulation by reducing the local biogenic ammonia. Now, the diathermy and ultrasound, these are very important as they are more effective method of treatment in a deeper muscle. It produces heat and improves the local circulation. Now, up till now, we chose the treatment as per the etiology. Now, here in other therapies, we have hypnotherapy as the treatment modality where anxiety has been taken care. Anxiety or stress level when we think that the other treatment modality cannot be applicable. Okay, here patient's cooperation is essential. He or she should follow the suggestions of hypnotist. It is an individual belief that aid in the following suggestions of the hypnotist. By this method, muscle will be relaxed. Acupuncture, again it is a simple, effective, conservative pain control modality accomplished by inserting needles into appropriate points at the appropriate surface called meridian. These meridians are generally associated with the major nerve, artery, pathways, joints, and facial pains. Now the needles are placed in these meridian areas and the pain is relieved. Here the pain is relieved, but the basic cause does not relieved. Now to summarize, Mpds is a psychophysiologically altered condition involving the muscle constipation and cervical group of muscles. The condition, characterized by dull aching, radiating pain, often results in muscle spasm and restricted movement. An accurate diagnosis is accomplished by careful history taking and thorough examination. Thus the therapy should be directed towards reducing stress, rehabilitating the occlusion, and relaxing the muscle to alleviate the condition. That all these things, etiological factors should be taken care. So to conclude, a better understanding and working knowledge of myofascial trigger point and myofascial syndrome offers an effective approach to relieve pain and restore functions in patients. Thank you, students. Hope you understand the topic. If not, if you have any queries, you can write to me at my email.